Thank you so much for coming. My name is Emily Pinto Taylor, and I'm a geriatrics fellow at Emory. I've been so thankful to work with and be mentored by Dr. Molly Perkins and other Emory investigators on our team, as well as investigators from the Veterans Aging Cohort Study, who study the long-term impacts of HIV on aging veterans. Over this past year, we've embarked on a project to learn more about barriers to advanced care planning for this population, specifically within the context of the patient-clinician relationship. To begin, we'd like to disclose our funding support for this work from the Emory Center for AIDS Research. To start, some brief background. Thanks to the development of effective antiretroviral therapy, people living with HIV have been reaching older adulthood with a life expectancy similar to that of age-matched peers. Whereas in the beginning of the HIV/AIDS epidemic, advanced care planning formerly involved a rapid transition with AIDS onto hospice, as seen on the left, it now includes use of palliative care and hospice services for non-HIV-related terminal diagnoses, as seen on the right. Patients with HIV are living with and dying from the same age-related medical conditions that affect the general population, but they are less likely to be engaged in advanced care planning conversations than their age-matched peers. One review noted that the majority of patients living with HIV had variable exposure to advanced care planning. Less than half had end-of-life communication, and even fewer were advised about advanced directives, as seen here in the Georgia Advanced Directive. Physicians surveyed felt they had limited time and training to engage these conversations with this population. No studies have analyzed a broad sampling of aging people living with HIV to understand how their unique experiences may impact their ability to participate in advanced care planning and make plans for the end of life, perhaps explaining the low prevalence of completed advanced directives for this population. What factors must be navigated by the patient in order to effectively participate in these conversations, advocate for themselves, and receive care that reflects their personal preferences and improves their quality of life? Our objective was to answer this question and to better characterize advanced care planning experiences within this population. As a result, we undertook a qualitative analysis utilizing transcripts from a sample of US military veterans from the Veterans Aging Cohort Study, an observational, prospective, longitudinal study of HIV positive and age, race, sex, and site-matched HIV negative patients receiving care at US Department of Veterans Affairs medical centers across the United States. We used a thematic analysis approach to analyze 25 transcripts from semi-structured interviews recorded at the Atlanta VA with HIV positive veterans aged 50 to 72. Their characteristics, 60% African American and 80% male, mirrored the hospital population. Interviews ranged from 47 to 198 minutes, with a mean length of 98 minutes. We utilized inductive coding with principles of grounded theory, from which a core category was developed to link to all other categories, and a final storyline generated to denote these connections. So what did we find? The focus of our study was the limited completion of advanced directives or engagement in advanced care planning among people living with HIV. Only 9 of our 25 participants, or 36%, indicated engaging in advanced care planning for end of life. Following our interviews, we developed a storyline to denote connections between the core categories that arose from our coding conducted for thematic analysis. We will briefly touch on representative quotes for each component of the storyline, although there are hours of rich data that I wish we had time for. The central phenomenon we understand to explain the discrepancy in advanced directive completion is navigating unresolved grief. There are many ways in which participants refer to this central phenomenon, such as this participant who dropped out of a nursing program when his diagnosis was made, and when asked if he ever considered returning, stated,
"The greatest challenge of living with HIV is dealing with a sense of loss. It cost me a nursing profession. It cost me my future in nursing. I didn't think a nurse could be HIV positive. It didn't feel that way at the time. So I dropped out. And it cost me my relationship. I will never be able to have a normal relationship. I always wanted to have a family, a wife and a family, and I don't think I can ever get married again. So I lost that prospect."
Causal conditions are those situations which result in the phenomenon. In our study, we found themes of common experiences which participants grieved with variable resolution, such as prejudice, often faced from their military experience or social circles, as well as some prior prejudices from medical providers, trauma or assault history, the death of friends or partners, and the challenges with evolving knowledge about HIV.
After I learned about my HIV, I had given up both of my children to their father because I didn't know what I could do. And then I became a suicidal wreck.
I've watched so many of them die. George at the Baptist Hospital, my buddy called me up and he says, "Can I come in?" His partner was there, and I say, "Yeah, I can come." The nurses wouldn't clean him, so we bathed him and put clean clothes on him. 3 hours later, he passed away, and I told him, "I can't handle this anymore. I reached my breaking point."
The phenomenon is observed in a context, which can affect the phenomenon positively or negatively. In our study, we found a recurrent theme to be the influence that a positive relationship with one's medical team, especially the HIV treatment team, can have on a patient's perception of grief about their diagnosis. Although many veterans had experienced trauma during their military service, they were overwhelmingly complimentary of the care they received from their HIV doctors at the VA in particular.
I see the HIV doctors in VA hospital in a very good light, and I don't care what anyone else says about it or how bad the parking is or the medicine or anything like that. I'm grateful to be in a country where we have this. I see them as being supportive of being providers for veterans.
As participants explored their history of trauma, prejudice, and exposure to premature death and the grief they carried from these experiences, the resultant action was their lack of engagement with advanced care planning and limited completion of advanced directives. When directly asked about their expectations for the end of their lives, many participants agreed it was important to have thought about preferences, but hadn't done so.
That is funny that you asked that because I don't. And I was thinking about that last night. I don't want to be a burden to my children. I always have this stupid idea that I don't know. I guess all the drugs in my body don't really give a shit. I ain't going to worry about it. I'm dead. But I do worry about it now a little bit. But no, I don't really have anything.
We noted several intervening conditions which can affect advanced care planning engagement. Actions don't occur in a vacuum, but in a broader context. Certainly, some participants referred to having considered advanced care planning and fully discussed their wishes with their loved ones, but others hadn't. Those actions are impacted by some core themes which emerged and either facilitated or constrained engagement with advanced care planning. These intervening conditions included themes of negative resiliency, where participants saw themselves as survivors, having lived so long with their HIV diagnosis that they were unable to see an end to their life. One participant referred to believing he would outlive his elderly aunt, who was 104. Other participants described a strong sense of self-reliance, prior poor experience with hospice, the importance of privacy, secrecy from family members, and variably strong social ties. One veteran described a particularly challenging relationship with his sister.
I'm looking into going into a nursing home this month because I'm tired of living in my sister's house and paying her a fortune and not being able to get anything else from her except living in her house. If she saw me laying on the floor or stumbling by my bed and falling on the floor, she would not help me up.
Finally, the consequences of not engaging in advanced care planning discussions included unrealistic end-of-life wishes and a lack of formal advanced directive completion. One participant, when asked if he had any formal plans for end-of-life care in place, stated,
"I do need more assistance. I need assistance. I have a will that I wrote or something online, but I haven't paid for it yet. But I do need that done because you never know what's going to happen."
Another veteran I spoke with summed up his plan simply as call 911. There are many more quotes from our participants that were incredibly rich and detailed, and I wish I had time to share more with you today in this time constraint. In conclusion, as clinicians prepare to have advanced care planning conversations with aging patients living with HIV, it is evident that their unique history may impact their participation in these conversations. We have created an explanatory model based on these findings, and clinicians could target these conversations to the most at-risk patients through the use of various prognostic tools, such as the VAX Risk Index. We hope to further explore each patient's experience in order to increase engagement in advanced care planning and better execute their wishes at the end of life. The authors are grateful for the support and funding from the Emory Center for AIDS Research, as well as the support from the Veterans Aging Cohort Study team. Thank you very much.